I'll have a patient where their TSH is depressed. In this case, it's almost always undetectable. And because the thyroid hormones are normal, sometimes the person won't experience any symptoms. So they might not have the typical symptoms associated with Graves' disease, such as elevated resting heart rate, palpitations, tremors, anxiety, and other associated symptoms. If someone has a depressed TSH, it's common, even if the thyroid hormone levels are normal, for them to ask, should I take something that's anti-thyroid? Hey, this is Dr. Eric, and in this Q&A episode, I am going to answer the question, can a natural approach help with subclinical hyperthyroidism? What's subclinical hyperthyroidism with no autoimmune component? It's a little bit different, and sometimes it can be challenging, even though you would think that autoimmunity is more challenging than a non-autoimmune case of subclinical hyperthyroidism. That's not always the case. Now, is there a chance that someone could present with subclinical, let's say subclinical Graves' disease, or I guess even subclinical hyperthyroidism, where it's subclinical, but then eventually becomes clinical? I mean, that's the case whether Let's go ahead and start off by discussing what is subclinical hyperthyroidism, because there's a few different scenarios. And one scenario is a non-autoimmune case of subclinical hyperthyroidism. That's simply when someone has a low or depressed TSH, which is thyroid stimulating hormone, and their thyroid hormones, both T3, T4, are within the lab reference range, and perhaps within the optimal range as well. Sometimes it might actually be a little bit on the higher side, but still within that lab range. But TSH is low. Sometimes it might be completely depressed, like it might be undetectable, like less than 0.001, or some labs will be like less than 0.05. Sometimes we'll see TSH low, but within the range. So maybe like 0.19, for example, or 0.27. And so that's one example of subclinical hyperthyroidism. There's also subclinical Graves' disease. And subclinical Graves' disease, not as common, but every now and then I'll have a patient where their TSH is depressed. Again, in this case, it's almost always undetectable. So again, less than 0.001, for example, and T3 and T4 will be within the lab reference range. Again, might be a little bit on the higher side, but still within the lab range. And then the person will have elevated thyroid stimulating immunoglobulins, which are the antibodies associated with Graves' disease. And also should mention that because the thyroid hormones are normal, sometimes the person won't experience any symptoms. So they might not have the typical symptoms associated with Graves' disease, such as elevated resting heart rate, palpitations, tremors, anxiety, and other associated symptoms. Some people, though, do have the symptoms, even though the thyroid hormone levels are within the normal range. Again, especially if they're on the higher side, that might still experience symptoms. Now, with subclinical Graves' disease, because you do have that autoimmune component, you could have thyroid eye disease. Thyroid eye disease is when the immune system attacks the tissues of the eyes. And so if you have those thyroid stimulating immunoglobulins, you could have those attack the tissues of the eyes, even if the thyroid hormones are normal. So did want to mention that. So that's really the difference. So again, the blood test will, the thyroid hormones will be within the lab range. The person may or may not experience symptoms. And so now the next question might be, should someone take antithyroid medication or Bugleweed or motherwort? Are any antithyroid agents necessary? Well, motherwort's not an antithyroid agent, but let's say Bugleweed or something like methimazole, or again, maybe motherwort for cardiovascular symptoms. So if someone's not experiencing symptoms, like if they're not having elevated resting heart rate, palpitations, the cardiovascular symptoms commonly associated with hyperthyroidism, then chances are they probably wouldn't need to take something like motherwort. But how about Bugleweed, or again, antithyroid medication? Because if someone has a depressed TSH, it's common, even if the thyroid hormone levels are normal, for them to ask, should I take something that's anti-thyroid? And if someone, well, let me say this. If someone, let's say someone has just Graves' disease, not subclinical Graves' disease, and their thyroid hormones are elevated, so T3, T4 elevated, TSH depressed, And so let's say that I recommend Bugleweed. Let's say they're not taking antithyroid medication. I put them on Bugleweed, and then their thyroid hormones eventually normalize and their TSH is still depressed, which is common. A lot of times it takes a good amount of time for the TSH to increase. In this situation, I would tell them to stay on the Bugleweed. I wouldn't tell them to start weaning off the Bugleweed because the thyroid hormones are normal. I would tell them to stay on the Bugleweed, and let's wait and see, not if, but it's usually just a matter of time when the TSH will increase. And then once the TSH starts to increase, especially like when it's over 1, I think it's a good idea to start decreasing the Bugleweed. But with subclinical hyperthyroidism, it is a little bit different. So, I mean, if someone has normal thyroid hormones right from the start and a depressed TSH, I mean, it's not that it's a bad thing necessarily to give something like Bugleweed, or even, I guess, in some cases, antithyroid medication. But you, of course, either way, you want to try to address the cause of the problem. I mean, that's the case whether it's subclinical hyperthyroidism, subclinical Graves' disease, or just Graves' disease, period. But in the situation when someone has Graves' disease and it's not subclinical, again, I will have them stay on the Bugleweed even when the TSH is depressed. But that's not the main reason I'm keeping them on the Bugleweed. The main reason I'm keeping them on the Bugleweed is because the concern is if they stop the Bugleweed, that their T3 and T4 might become elevated again as it was initially. But we're not looking at that with subclinical hyperthyroidism or subclinical Graves. Now, is there a chance that someone could present with subclinical, let's say subclinical Graves' disease, or I guess even subclinical hyperthyroidism, where it's subclinical, but then eventually becomes clinical, like where the T3 and T4 elevate? If you are looking to do everything you can to save your thyroid, in addition to watching my videos on YouTube, you also might want to subscribe to my free online newsletter, which is called Healthy Gut, Healthy Thyroid. Not only will you get the latest news on how to heal your gut and restore your thyroid health, but during each edition, I'll demonstrate a different blood or functional medicine test marker that relates to healing your gut and or your thyroid. There will also be an Ask Dr. Eric section where not only can you see questions that other people have asked related to gut and thyroid health, but you can also submit a question for me to answer in a future edition. To subscribe to the Healthy Gut, Healthy Thyroid newsletter, please visit savemythyroid.com/newsletter. Yeah, of course, there's that possibility. And that's why you still want to keep on top of this and do regular blood tests, like not do blood tests every 6 months, but ideally every 6 to 8 weeks, maybe in some cases sooner than that, some cases on a monthly basis. But yeah, so with subclinical hyperthyroidism, subclinical Graves' disease, I can't say I always recommend for someone to take Bugleweed. And I think antithyroid medication, the concern with that is that they might become hypo. But even if they're on a low dose of methimazole, let's say, it's not doing anything for the cause of the problem. And it's not, I mean, that's always the case, but it's not, yeah, I mean, risk versus benefits. Again, I'm not going to tell anybody not to take antithyroid medication if they have subclinical hyperthyroidism, but in this situation, I'm not sure if the risks outweigh the benefits. Now, that being said, is there a concern if the TSH is low, but thyroid hormone levels are normal? So that maybe cardiovascular wise, there's not that concern, but is there concern from a bone density perspective? Because hyperthyroidism itself definitely affects the bone density, but how about subclinical hyperthyroidism? So some of the research does show that subclinical hyperthyroidism, so even just the TSH alone, can potentially affect bone density in a negative way. Now, what you could do is, and what I recommend doing, is to get a comprehensive metabolic panel and look at alkaline phosphatase. And alkaline phosphatase, a lot of times, actually most of the time with hyperthyroidism, it will be elevated, and that usually is related to the bone turnover. And so you could do an alkaline phosphatase, and there are other bone markers as well, like CTX. I mean, you could do those, but I think even just looking at alkaline phosphatase many times is sufficient. And if alkaline phosphatase is elevated in the presence of a low TSH, then they might want to take something like Bugleweed to try to get that TSH up, even though it's not addressing the cause of the problem. But if it's preventing bone loss, obviously that's important. So did want to mention that. And then as far as treatment options, so again, whether or not someone takes Bugleweed or antithyroid medication or something else for to increase the TSH, again, those aren't doing anything to address the cause of the problem. So for subclinical Graves' disease, the treatment really isn't much different than what regular Graves. I mean, from a symptom management aspect, it might differ, but it's autoimmune. So you still want to do things to find and remove triggers. You want to do things to heal the gut. So everything I talk about in my books, the hyperthyroid healing diet, as well as natural treatment solutions for hyperthyroidism and Graves' disease, it would still apply for those who have subclinical Graves' disease. Now, with subclinical hyperthyroidism with no autoimmune component, it's a little bit different. And sometimes it can be challenging, even though you would think that autoimmunity is more challenging than a non-autoimmune case of subclinical hyperthyroidism. That's not always the case. But if I'm working with someone who has subclinical hyperthyroidism, I'm still going to take a similar approach. I mean, they might not need to follow as strict of a diet like an autoimmune protocol, since it's not autoimmune, but I'm still going to recommend to eat a whole food, anti-inflammatory diet, let's say a paleo diet, or again, if you've read the hyperthyroid healing diet, a level 2 diet, which is a modified paleo diet. Still do things from a stress management perspective. I mean, so the foundations are important. So eating well, stress management, proper sleep, and then just doing things to optimize adrenals, which relate to stress management, again, proper sleep. So optimize adrenals, do things to heal the gut, to reduce toxic burden. So that's the approach I've taken with my patients who have subclinical hyperthyroidism. And many times by incorporating the foundations, optimizing adrenals, gut, liver, we will over time see that TSH increase. It's just like Graves, it is a gradual process. And I can't say I have a 100% success rate when it comes to subclinical hyperthyroidism, but that's the approach I take. And many times it will help to not only increase that TSH, but to eventually normalize the TSH. So that is my answer to the question. Can a natural approach help with subclinical hyperthyroidism? So my answer is yes, it can potentially help, because regardless of whether someone has non-autoimmune case of subclinical hyperthyroidism or subclinical Graves' disease or just regular Graves' disease, you always want to try to do things to address the cause of the problem. As usual, I hope you found this Q&A episode to be valuable, and I look forward to catching you in the next episode.